Right. Good morning, everyone, or good afternoon, I should say. My name's Emma Russell-Jones, and next door to me is Sarah, and we've got one of the consultants who's very kindly, Macto, who's coming to present on the paediatric nephrology session today. The aim of this case exchange is to try and deliver regional ST1 to 3 teaching, specifically designed around common cases and common topics that you and I see on a day-to-day basis, but also focusing particularly on the written and clinical exams. These sessions will consist of a presentation by one of the SHOs, consultant teaching, and some MCQ questions within a particular topic. All of the topics will be on a monthly basis, and they'll be announced in the one before, and it maps well with the curriculum and any exam prep that you guys are doing. If people would like to volunteer to present, they would be most welcome. And if you drop myself, Sir Emma Russell-Jones, or Sarah Sturrock an email, we would gladly be keen for that. And we will be sending you feedback forms, which Sarah has put a link in the chat, and certificates to presenters for portfolios. So without further ado, I'd like to hand over to our first speaker today, who is Louise Morby.
I'll put my camera on. So hi everyone, my name's Louise. I'm one of the ST3s currently at the Evelina on NICU. I'm going to present a case of a little girl who I looked after last year now on Beach Ward at the Evelina Children's Hospital. I'll turn my camera off whilst I'm presenting. So without further ado, this is a presentation of DC. She's a 4-year-old little girl. She was a transfer in to the Evelina Children's Hospital, so she initially presented to Darren Valley Hospital in October last year, and then she was transferred to us 2 days later. So the history of her presenting complaint. So she had 2 days history of, oh, you can't see all of my slides, can you? They're cut off at the bottom. Can you see them, Emma, or not?
Yes.
Can you see all of
not the very end. Not the very end.
How odd. I don't know how to fix that. Let me see if I can do sex. Can you see my screen now? Better?
I can still see your screen, but I can't see the very bottom of the slide.
Would you be able to try with yours, the one I've sent? You sure?
Let me. I can try.
Or I can get up on my phone and read the rest. Sorry, guys.
Just getting your presentation up, Louise, to see if I can help.
See what's down to the suspense. See what happens.
Louise, the other thing to try is that sometimes if you're there's the option to share your screen or share your application, and sometimes it works better if you do share screen rather than share application.
My IT abilities are poor.
No, don't worry. It's a slightly odd way that they do it, but sometimes that helps get like the big version of your slides.
That's better.
Perfect. Yeah, I can see what needs to be a whole slide.
Emma, do you mind clicking through for me, please? Fine, thank you. So this is a case presentation of a little girl called DC. She's a 4-year-old girl who was transferred to the Evelina last October. So there was somewhat limited history in the notes from Darrant Valley, but she presented to A&E there with a 2-day history of vomiting, headache, and some periorbital edema as well. On questioning of her parents, also established that she'd actually been anuric for the previous 24 hours prior to presentation. She'd had a petechial rash over her back and abdomen and was felt to be lethargic by her parents, and it was the lethargy that prompted them to attend A&E. Kind of significant negatives in the history. There was no history of her ever being pyrexial, and she wasn't pyrexial when she presented, and she had no history of diarrhea either. She'd done well in the preceding couple of weeks prior to presentation. She hadn't had any contact that they'd known of with any unwell people. Thanks, Emma. Extended history. She was an only child. She was born at term with no significant neonatal history, and she'd been well previously with kind of no real need to attend hospital before. She lived with both of her parents. She was fully vaccinated. There was no social service involvement. Mum was 31 weeks pregnant at the time. Travel history. So DC hadn't travelled herself, but her dad had returned from Dubai 4 days prior to her becoming unwell. But he in himself as well. And she's not had any significant farm or petting zoo contact either, which was a clue to the diagnosis maybe. Thanks, Emma. So on examination, and this is the clerking from Darrant Valley, her area was patent and she was talking in full sentences. She had no real chest signs with no work of breathing. Heart sounds were normal, but she was found to have a soft systolic murmur, and this is documented as query of flow murmur relating to her being unwell. Her abdomen was soft. She had nil organomegaly, and both her renal angles were clear as well. She was noted to have a petechial rash over her abdomen and left flank. ENT was normal, and she did have some periorbital edema noted as well. She was felt to be lethargic and not quite right in A&E at Darrant Valley. So I think mainly because of the petechial rash and the lethargy, she was screened and treated for sepsis and commenced an IV ceftriaxone. They had concerns about meningococcal due to her petechial rash and headache as well. She was given a 20 ml per kilo fluid bolus due to the anuria, with the kind of working rationale at that point thinking she might have been dehydrated in the context of sepsis causing renal impairment and anuria. And she was committed to the children's ward at Darrant Valley for ongoing monitoring and IV antibiotics and fluids. And then her initial investigations at Darrant Valley, some of her BPs were a little bit hypertensive for her on her centile, so up to 130, and that was taken when she was settled as well. Bloods-wise, electrolytes were kind of the only significant bloods at that point, so she had a raised potassium at 5.7 with a raised creatinine at 117 and the urea of 21.7 as well. Her hemoglobin at that time was 111. The bloods were repeated the next day after she'd had kind of 24 hours of fluid and IV antibiotics. Unfortunately, at that point, her creatinine was still rising, as was her urea, and at that point, it was noted her hemoglobin had dropped to 100 as well. On further discussion with kind of the Evelina, they'd asked for a hemolysis screen, and her LDH was kind of 2,000, and they'd added a blood film on to those bloods, which showed evidence of fragments. So she was then further discussed and transferred over to us as a possible hemolytic uremic syndrome, or HUS. So this was ongoing management on the ward at Down Valley. So she had worsening renal function despite kind of fluid resuscitation. She had started passing urine, but only a small amount, and her periorbital edema was felt to be worsening, and she was developing some pedal edema as well. So Evelina advised to restrict her fluid balance, do the hemolysis screen, which was done, and then she was transferred over, as I said. So on arrival to us, BP systolics with us, actually, so I've not filled it in, were a maximum of 115, which is borderline hypertensive for her height and weight, but that actually were resolved as she got better. The bloods that we did on her admission, so she was significantly anemic with a HB of 83, and her platelets were low as well at 41. Her renal function unfortunately had worsened again by the time she got to us, with a creatinine of 166, an urea of 30.4. Her LDH had come down a little bit. At this point, sorry, I've not put it in, her urine output was about 1 ml per kilo per hour, and that was while she was fluid restricted to about 400 mils. Blood gas on admission was kind of a compensated metabolic acidosis, so her bicarb was low at 10.7 and her base excess is minus 13.2. And again, note that her HB is low on the gas. And just here, she had lots and lots of blood tests taken, and I've not kind of included them all because they're showing a similar picture, but I've just given her kind of interim blood tests that were taken on the 14th, just as a trend. So on the 14th, her hemoglobin was 69. Her platelets had improved at that point, come up to 323, and her creatinine had started to improve as well at 106, with the urea falling at 13.4. The 14th is kind of where she started to improve. She'd had a few days on the ward where she was fluid restricted, and kind of, as I'll come on to, managed with mainly supportive management. So main problems for DC on the ward were basically some fluid overload. So she was fluid restricted whilst her renal function improved, just titrating her fluid allowance basically to her urine output. She was also very kind of unwilling to eat, and we know in the context of renal disease, the nutrition is very important. The catabolism that will happen if children aren't eating will drive that increase in their urea as well. So we needed specific input from our renal dietitian to help provide a high calorie feed in the context of fluid restriction as well. So she had some NG feed supplementation. She was supported with kind of bicarb supplements. She had some potassium binders and electrolyte management as well. Thankfully, DC never needed any dialysis, but it's not uncommon for severe HUS cases to need dialysis if you're unable to get on top of their electrolyte disturbance and or their fluid overload as well. Something that I learned whilst looking after HUS cases was you kind of need to tolerate some quite low hematology transfusion limits, and usually because if you give them blood products, the hemolysis kind of process will mean that these blood products are consumed anyway, and you kind of need to wait for the process to just run its course. So DC never got any transfusion products, and that's because actually she did manage to tolerate her low hemoglobin and low platelets without any adverse outcomes, which was good for her. If, of course, she needed any surgical intervention or she became compromised, then she may well have ended up being transfused. And again, a learning point for me for management is antibiotics. So the ceftriaxone that she was started on was stopped when her blood cultures were negative. Confer no benefit as it's a toxin-mediated process. Thank you, Emma. This is just brings me on to the next point. So her blood cultures were negative. Her stool culture, so typically when you think of hemolytic uremic syndrome, the textbooks and kind of learning materials will tell you it's associated with an E. coli positive diarrhea or bloody diarrhea. Her stool cultures were negative, and an important fact for her presentation is that she never actually presented with diarrhea either. Her urine culture was also negative. She had a respiratory file panel that was negative. Her PCR for meningococcal disease was also negative. She had a hepatitis screen as part of her work up was negative. the kind of clinching bit of information that we managed to glean is she had a rectal swab when she got to the Evelina that was sent to the Collindale lab, and she was found to be VTEC positive. So therefore we're able to confirm her diagnosis of typical HUS. So now brings me on to talking a little bit more about hemolytic uremic syndrome. So it's a kind of classical triad that you'll learn in your textbooks as well. So microangiopathic hemolytic anemia, there needs to be evidence of red cell breakdown or fragmentation on blood films and associated acute kidney injury as well. It's most commonly caused by an enteric bacteria E. coli, but it can be caused by other pathogens as well. And the other pathogen that I most commonly know it's associated is with strep pneumonia. You need to be able to differentiate between a typical and an atypical HUS. So originally when DC presented, there was a concern that she might have been an atypical HUS because she had no positive contact history with anyone with diarrhea symptoms, no contact with any petting zoos. She was afebrile and she didn't necessarily fit that typical infective picture. So an atypical HUS is not usually related to infection but presents with the same findings. So hemolytic anemia, red cell fragmentation and acute kidney injury, but usually is associated with kind of a complement abnormality or other conditions such as malignancy, SLE, or can be drug induced as well. One of the main differences between atypical HUS is that it has a slightly poorer prognosis, it has a more progressive relapsing course, whereas a typical infective HUS will usually, if you escape severe kidney injury, you get it once and then kind of recover from that point of view. So a bit about pathophysiology of HUS, and this is for typical HUS. I'm not going to go into the atypical HUS because I'm not clever enough. So it's usually following infection with a sugar toxin producing E. coli, and that's the STEC or the VTEC that's reported in the lab results. So the natural reservoir of this is usually in the intestines of ruminants, so cows, and that's why we think about kind of petting zoos and farms as reservoirs for infection. It's usually following infection of contaminated food, direct contact with these animals, or if you get a person-to-person spread of someone who's been infected that way as well. So the circulating toxin binds to your endothelial receptors, and these kind of have a proficiency for the renal, gut, and CNS endothelial receptors as well. This causes thrombin and fibrin to get deposited in the microvasculature, and then the ureterocytes are damaged as they pass through these partially occluded vessels, and that is what triggers the hemolysis. So these are kind of the possible complications of HUS. So some children unfortunately go on to develop long-term renal impairment, which may require kind of long-term dialysis and renal transplant as well. You can get colonic necrosis and perforation related to diarrhea. Lots of children present with significant CNS disturbance, which is most commonly seizure, coma. You can get pancreatitis and glucose disturbance, and there's been reports of some children having myocardial dysfunction, including myocardial infarcts as well. So I'm just going to speak a little bit about kind of neurological involvement in HUS, and this is because it was pertinent to DC herself. So some of the initial concerns that her parents raised is that she was suffering from headache and had some significant behaviour change as well, which spanned the whole course of her illness. They weren't sure if this was necessarily because she was hospitalised and feeling under the weather, or it was a new kind of pathophysiological change as well. Her parents, for most of her stay, were reporting these vacant episodes, but again, we're unsure if she was kind of traumatised and just ignoring them or actually vacant. Unfortunately, none of the medical staff themselves were actually there to witness these vacant episodes that they described. But she had ongoing complaints basically every day of her stay of this headache and double vision as well. And then later on in her stay, she went on to develop 2 episodes of tonic seizures. sorry, that should say both of them lasting less than 2 minutes, not more than 2 minutes. They were all self-resolving. She underwent a CT head due to these seizures, and that was thankfully reported as normal. It's just a learning point that I wanted to share, as I wasn't necessarily aware of the kind of neurological processes associated with HUS and how it can present as well. And the causes of this is again thought to be related to the kind of microangiopathic changes in the CNS vasculature, which manifests itself as CNS involvement. About 30% of children with HUS have neurological involvement, and the most common presentation we see this is with seizure. Now, again, something I learned about is a drug called Ecluzimab. It's a monoclonal antibody that is used in Haemolytic Uraemic syndrome. So initially it was used to treat atypical Haemolytic Uraemic syndrome, and then used to treat patients with significant neurological involvement as kind of a rescue therapy. But there's a trial going on now at the moment, which the Evelina are part of, calling the Ecluzimab trial, and that's a trial to try and see if Ecluzimab can help prevent acute kidney injury, chronic kidney injury in children presenting with HUS. I think it's unfortunately been held now that COVID's happened. This trial was offered to DC. Unfortunately, her parents declined involvement in the end, but a couple of our children did take it out whilst they were here. So just follow up on the case for DC. So she's been followed up since 6 monthly in renal clinic. Thankfully, her renal function has completely returned to normal. And from a medical and growth point of view, she's reported to be thriving. Unfortunately, she has got ongoing difficulties with what her parents are describing as significant psychological change and behavioural difficulties as well. She's been diagnosed with post-traumatic stress as a result of her inpatient stay, and is being seen by our psychology team to try and help with that. But we're just wondering whether the behavioural difficulties are purely the result of the traumatic inpatient stay, or if she's got some kind of ongoing disease process as a result of her neurological involvement, which she had kind of from the beginning of her course of illness. At the moment, they're going with the traumatic stress diagnosis. So these are learning points that I've learned with my 6 months kind of working the renal job, and that I would like to share is, first of all, your differentiations between typical and atypical HUS. One of the biggest learning point I think I've made is you do not have to have a positive history of diarrhea or farm animal contact to be diagnosed with HUS, and it's really important to work quite hard to try and establish that diagnosis. If you've got a negative stool sample, it doesn't mean that the child is necessarily negative. Neurological involvement, again, something I wasn't aware of, and maybe subtle, and it's more common than you realise, so you might have to look for it. Again, if unable to isolate from a stool sample, try a rectal swab. It's a notifiable disease. You need to inform Public Health in England, and also the child and their family need to isolate until they get negative swabs of stool samples as well. And then again, the monoclonal antibody treatments that are available for severe cases, so that's the Ecluzimab that I was talking about. That's it. Thank you very much, guys. If you've got any questions, we might have to stay them to the end.
Thank you very much, Louise. If anyone has any questions, feel free to write them in the chat or say. Okay, well, shall we move on to our next speaker now, who is Makto, who is one of the consultant paediatric nephrologists, talking about acute kidney injury. Thank you.
Thanks a lot, Emma, and Sarah, for organising today, and thank you everyone for coming for this first South London case exchange. I'm just going to spend about 20 minutes or so talking through key cases that both present clinically very often, and also will come up in exams because they're very common things that we see, and a few key kind of practice points about acute kidney injury in children. Can you all see me and hear the slides? So hear me and see the slides okay? All okay?
Yep, looks good to me.
Great, thank you. So I'm just going to move that on. So I'll use 3 cases, running through them quite quickly. That we get phone calls about these all the time, and you see them in a lot of district general hospitals, not just in tertiary renal units. So I've tried to make it relevant to that setting. So the first one is of edema, the second one of hematuria, and the third one of oligoanuria, which could exemplify the sort of broad range of conditions that can cause acute kidney injury in children. So this is, first of all, is a 7-year-old girl. This is not a real girl, she's from Google, and she has presented to A&E looking like this. She's got a 4-day history of increasing puffiness. She had a recent viral illness, and her parents noticed that she's been passing reduced amounts of urine. She doesn't have any fevers. She's got a bit of abdominal pain, but she is eating and drinking. And clinically, when you look at her, she's clearly edematous. Her chest is clear, her abdomen's soft, she doesn't have ascites, but she is quite cool peripherally when you examine her. She's never had a similar episode like this before. She doesn't have any other allergic symptoms, so often the diagnosis I'm going to tell you about is misdiagnosed as allergies. That's the typical story that these patients tell us the first few times, and often they'll go to the GP with allergies and be diagnosed and come back a few days later to your paediatric unit. She doesn't have any family history of similar symptoms, and the urine hasn't changed in colour. Her observations are there. She's otherwise, it says here, well perfused. And this is what her urine dipstick shows, 4+ proteinuria. Does anyone know what the diagnosis is here? You can put it in the chat if you want to. Don't worry if nobody wants to commit to it. So this is a case of nephrotic syndrome. And now in childhood, nephrotic syndrome is commonly what we call steroid sensitive, and response to that, and that's the majority of what we see. And the initial investigations we'd do when you see a patient like this in A&E, if they're edematous and they've got heavy proteinuria, is to send some bloods off to the lab. And really the key ones are the urine for a protein creatinine ratio to accurately quantify that. But you know if it's 4+ and they're edematous, that's likely to be significantly abnormal. The second line of tests here is key, so the full blood count, the usinase, and the albumin. The rest of it is, if you can send them off, that's great. Things like serology are useful in case you get infections in the future. But really, it's the first and second line of those tests that are the most important. So this is a bit of further information about this case now. So we can see here that the hemoglobin is quite high at 170. Platelets are also high. And the creatinine for a child of this age is significantly abnormal at 89. And that urea is really abnormal. You can see here there's a low sodium and a slightly high potassium. And you can see here that the albumin is consistent with nephrotic syndrome, which is the triad of edema, a low serum albumin, so less than 20, and heavy proteinuria. So the protein creatinine ratio is over 2,000, and you need one above 300 to be diagnosed as nephrotic. But not only does this child have nephrotic syndrome, she's clearly got evidence of acute kidney injury with that creatinine and that urea. Now, the urea might seem disproportionately high, and we see that quite a lot in the nephrotics because they hyperfilter. So the creatinine might not be as high as the urea. In terms of proportion, you might expect a worse creatinine for that urea. And the hemoglobin being high is also important because it suggests that this child has the most common reason for a nephrotic to have acute kidney injury, and that's intravascular depletion. So although she's got too much fluid on board overall, hence why she's edematous, intravascularly, she's actually dehydrated. So she's hemoconcentrated, and that's what's caused her acute kidney injury. So what do we do about these patients on the ward? Well, if they're this severe, generally we would get them discussed with a tertiary renal centre. If they're a simple nephrotic, many general paediatricians would manage this in a district general hospital. The important things are regular observations, including the blood pressures, regular weights, input-output measurements, and clearly if the potassium is raised, that's the most urgent thing to manage. In this case, because she has got evidence of intravascular volume depletion, generally, we would recommend giving some fluid and then reassessing. I'd be careful not to give too much fluid because fluid overload not only makes things worse in nephrotics, but it can also make your outcome worse in acute kidney injury. And clearly, at some point, she'll need a renal ultrasound. And also, we need to manage the underlying cause of her acute kidney injury, which is her nephrotic syndrome. And that's generally with steroids, but that's a separate talk in itself. So this is the first example of the causes of acute kidney injury, and I still use this approach to think about acute kidney injury because I think it's really helpful. So you learn this in your adult medicine, but the most common causes of acute kidney injury in the general paediatric population are pre-renal, and clearly dehydration, not only in the context of nephrotic syndrome, but also in simple gastroenteritis, diarrhea and vomiting, are crucial, and sepsis as well. Thankfully, blood loss is less common in the paediatric population, unless it's a trauma case or something like that, but we do see that. So I'll move on to the second case now. This is an 8-year-old boy, another very common presentation. He's come in with what's called Coca-Cola urine. And clearly we're thinking when we have urine that looks like this, that this is blood in the urine. One of the important things to think about is it truly Coca-Cola urine, which is the type that we see as nephrologists very often, and that's glomerular bleeding, because the red cells from the time they've gone through your glomerulus have been deformed with all the kidney tubules, and they come out looking brown, almost black like Coca-Cola. Or is it actually bright red blood? In which case your differential diagnosis is really quite different, and you think about extraglomerular causes on the right here. Now, in adults, everyone thinks of cancer when you have bright red blood in the urine, but in children that's incredibly uncommon. So you think about other things such as urine infections, occasionally stones, and trauma can be a cause. But the type of bleeding in the urine that we tend to see is the glomerular type, which presents with this kind of dark brown urine. And the most common cause that you'll find, and the most common cause that you'll certainly find in exams, is post-infectious glomerulonephritis. So that's PIGN, also known as post-streptococcal glomerulonephritis. But there are some other much rarer causes. And probably the biggest differential diagnosis is IgA nephropathy. And that's an important one to differentiate for your written exams as well. And I'll mention that in a minute. So this boy has had a 2-day history of progressively darker urine. He's had a decreased urine output. He's slightly tired, but otherwise he's well. And he's had a lot of mild illnesses since he went back to school, but that's not uncommon. Examining him, he looks well. He's not edematous, but his blood pressure is a little bit high at 120, which is a bit high for an 8-year-old boy. His results are here. So you can see he's got blood and protein on his dipstick. But when you have frank blood, a little bit of protein urine itself isn't surprising. His protein creatinine ratio is raised, but it's not nephrotic range, which, if you remember from before, is about 300. He's also got a raised creatinine and a raised urea. And importantly here, he's got a C3 that's low with a normal C4. And that's really important because that's typical of post-infectious or post-streptococcal glomerulonephritis. And that's the typical picture that we see. If your C4 is also low, then that makes you think about other rarer things, such as lupus. And then to confirm the diagnosis here, you've got an ASOT that's raised. So that's a typical blood picture for post-infectious, post-streptococcal glomerulonephritis. Now, another thing that's important to know about is your consultant says they want to give him Coamoxiclab, but is unsure of the dose because his creatinine is raised. Does anyone know how to calculate his kidney function? Again, there's always a delay on these things on the chat, but if anyone knows of any formulas, you can put them in the chat. Generally, in both the Evelina and at Great Ormond Street, the formula that we use is the Schwartz formula. And I think this is a really important thing to remember for your practice on the wards, because it means that you can quickly adjust the doses of drugs for kidney function. It's a simple formula like this, and the constant that you use is generally between 30 and 40. So if you're asked to adjust drug doses by one of our teams when you've got a patient with acute kidney injury, important to just refer to one of these formulas. If you don't know, always ask the renal team and they'll be able to tell you it. And really important because if you're giving drugs in the context of acute kidney injury, things can be made worse if the appropriate doses aren't used. So it's an important little practice point to remember that you can use that formula to estimate your glomerular filtration rate, and the adult formulas clearly don't apply, particularly in smaller children. So post-streptococcal glomerulonephritis, just a couple of slides on the condition itself. It happens a couple of weeks, typically 10 days or so after the acute infection with strep pyogenes, and it gives you this acute nephritic syndrome. So it's different to the nephrotic syndrome we saw before, and typically it gives you glomerular hematuria, there's edema, and there might be hypertension and impaired renal function, but not in all cases. In many cases, it's just the glomerular hematuria, and that's it. Otherwise, they're well with normal kidney function. No talk about kidneys would be complete without a glomerulus. Clearly, this is a glomerulus here, and there are lots of inflammatory cells. It's a very crowded one, and you can understand, therefore, how these patients can reduce their urine output and get edematous, because all their glomeruli get crowded by immune cells, and then they can't excrete the urine, and they retain the fluid and the salt, and then they get hypertensive as well as edematous. How do we manage them? Well, generally, it's supportive care. You give some Pen-V to stop the spread of these group A streps, and we regularly follow them up with weights and blood pressures. You'd recheck their urine and blood tests if they're abnormal, but if they were normal on the first occasion and there are no adverse clinical signs, then you might just review them as an outpatient every few days and then every few weeks. If they're admitted, then we do the similar to the last one, and we manage their fluid status, and we often use furosemide in these cases if they're edematous and hypertensive. So this is an example of the renal causes of acute kidney injury. One of the most common ones, as I said, is glomerulonephritis, with post-infectious being the most common one we see. As Louise has just very clearly presented, HUS is another relatively rare but important cause in children, and that's one that comes up probably disproportionately in exams because it's a pediatric pathology, so it's an important one to know about for your exams. And then some of these rarer things, drugs, tubulointerstitial nephritis, and a bad pyelonephritis can also give you acute kidney injury. So moving on to my last case, you can see in this picture what I'm probably going to be talking about. Yeah, it's the last stage, and that's the post-renal causes. So this is an antenatal ultrasound of a baby, a male infant, and you can see here along the spine, and then pointed out here, there's a dilated bladder and a dilated urethra as well that we're seeing here. In terms of the history of this case, it's an uneventful pregnancy, but this was noted to be dilated on a 20-week scan, but for whatever reason wasn't followed up. And we do sadly see a couple of cases like this where things aren't followed up appropriately and they present in the first few weeks of life. And in this case, it was because the urinary stream wasn't very good, and that was noted by the parents. When you do a renal ultrasound, you can see there's dilatation up to the kidneys as well, so not just the bladder, but up to the kidneys. And any bilateral kidney dilatation or bilateral hydronephrosis in a male needs fairly urgent investigation under urology and nephrology. The investigation of choice in this condition, and some of you might already be working out what this is something called an MCUG, a micturating cystourethrogram, and that's where we want to look at the anatomy of the urinary tract in a lot of detail. The diagnosis we're looking for here, and we're expecting in a male with a big bladder and bilateral kidney dilatation, is something called posterior urethral valves. It's a congenital anomaly, happens only in boys, and it's where you get sort of fibrous valves at the back of the urethra that give you this kind of dilatation that you see here. And then you can imagine if there's a blockage in the urethra, there's dilatation of the bladder and up to the kidneys. When you see these babies, or when you have them in the neonatal unit, the management's generally with a urinary catheter, and then initially some medical stabilization. We always ask you to speak to the pediatric urologist first, because drainage of the system in this cause of acute kidney injury is the most important thing. And then if the creatinine is very bad or if the fluid status is difficult to manage, we also ask for them to be discussed in nephrology. But we don't discuss all of these cases if the kidney function is okay. The definitive management of this obstruction is cystoscopic resection, and that's a fairly simple procedure that the urologists do. But as medics, the important thing to remember with these babies is that they need close monitoring of their fluid status, as they can have a significant salt and fluid loss after the relief of their obstruction. And that's an important thing to think about in all cases of acute kidney injury that are obstructive, is that after you relieve the obstruction, you can actually become quite polyuric and need quite a lot of salt supplementation to keep on top of things. Generally then they need regular follow-up, and we give them antibiotic prophylaxis. And as well as having chronic kidney disease, a lot of these children will have problems from incontinence and bladder dysfunction in the future. So in terms of what causes post-renal causes of AKI in children, well, the most common thing by a long way are the obstructive uropathies. Posterior urethral valves is the most common one we see. Occasionally we see stones, but in the general pediatric that's not very common. And extrinsic compression sometimes comes up as well. So occasionally tumours and things can push on the structures and cause obstruction. But relatively, that's the least common cause. So the most common cause we see is the pre-renal in general pediatrics, and then the renal causes, and then the post-renal causes. In the general pediatric setting are less common, but in the surgical setting they're clearly quite common. So I'll finish before we go on to Sarah and Emma's exam discussion, just on a few key points on the management of acute kidney injury in children. So I've talked already about the main causes. I think it's always really important to think about what your cause is and where in the system it is, because it affects how you manage them and what the key issues are. So clearly, if you've got a post-renal cause and you relieve the obstruction, you need to think about the fluid and salt balance afterwards. I've taken these few slides from our guideline on AKI, which is adapted from the national ones, and I'll show you the link at the end. If you do have a case of paediatric AKI, always have a look at the national guidelines. They're very good, they're very comprehensive, and they're very easy to understand. Before even getting to the stage of AKI, what we want to do is try and prevent it from happening. And we do that by trying to keep in our minds what kind of children are at high risk of AKI. Now, clearly, I think about this a lot, but when you've got sort of 6 wheezes and 4 bronchiolitis on your ward, AKI might not be at the top of your mind. But I'd encourage you just to have it in the back of your minds when you're thinking about the patients that come in. Clearly, these are the patients that are at very high risk, and I've put in red here the ones that are common or really important. So having some medications like the ones we give that affect kidney function can be a risk factor for acute kidney. Dehydration is a really common one in the general paediatric population. Clearly children with sepsis because of their intravascular depletion when they get their fluid leak, and children undergoing surgery. And clearly if they've got a known urinary tract obstruction or anomaly, then they're also at risk. But I think in general paediatrics, it's always really important to remember that many children are dependent on others for access to their fluids. So it's important, and clearly infants are that by default. So it's important to think that all infants are effectively at significantly increased risk of AKI because they're dependent on their parents or caregivers for fluid. And the important thing, as I've said, is to try and prevent AKI. And when you see the creatinine rise, that's when the damage in the kidneys has already happened. Often it doesn't rise in the first 12 hours. So once it's rising, the damage has already happened and you're actually often in the recovery phase. So that's clearly, you can prevent it by monitoring it, so making sure that you're observing for a low blood pressure, tachycardia, evidence of intravascular depletion, and clearly monitoring the electrolytes is important. We also want to make sure that we maintain the circulation, so try and avoid dehydration. And if you do think they're dehydrated, a fluid challenge and then reassessment is the right course of action. And then if you have got an AKI, then try to reduce any further kidney insults. So things like reviewing the medications. As I've said, you can use the Schwartz formula to calculate the estimated GFR and make sure that you adjust any medications for the level of kidney function. And also you want to make sure that there's no urinary tract obstruction there as well, which can make things worse. And clearly if you're pumping fluids into a patient who's got an obstructed urinary tract, they're just going to make more urine and make the kidney injury worse. So it's always important in all these cases to get a kidney ultrasound as soon as you realistically can. This is just a little management algorithm here, and it just exemplifies the things we've already talked about. So monitoring them both with observations and with blood tests and with a renal ultrasound when you can. Try and avoid potassium-containing fluids if you can, certainly in the initial phases when you don't know which way this is going. You minimize the kidney injury with the drug and dose modifications, and you treat any low, any hypoperfusion adequately. And then you keep monitoring and reviewing. And over here on the left side, I've put some, so this is for our internal guideline, but these are the things that I would suggest discussing with the renal team. So clearly a markedly hyperkalemic patient, often they'll be the ones who are oligo or anuric, a very low sodium as well, because they can be difficult to manage. If they're markedly hypertensive, certainly if they've got pulmonary edema, and if they've got AKI stage 3, so that's a serum creatinine more than 3 times their baseline, or any other sort of worrying or clinically concerning features, like as Louise said, an HUS with other features such as neurological features, you'd want to discuss with the kidney team quite early on. This is the website, it's called Think Kidneys, and it's got a lot of adult stuff on it, but there's also a pediatric page, and there's some great advice here and some guidelines, and that's where the one I've mentioned has come from. So if you do need a quick reference guide, this is the place to come when you've got cases like this. Thank you very much for your time. If there are any questions, happy to take them, otherwise I'll move on to Emma and Sarah.
All right, any questions, feel free to post them in the chat, or you can take your microphone off mute for a second and ask anything.
Thank you very much. Okay, so let's move on to Sarah's presentation now, the MCQs. But just before I hand over, just wanted to say the next case exchange will be on the 4th of January, and the between 1 and 2 again, and the topic will be neonatology. We then move as of February onto the first Tuesday of the month rather than the first Monday. And we're kicking off with paediatric neurology in February. Okay, Sarah, over to you.
All right, so we are going to go through some exam. Oh, we do actually have a question before we move on. Matko, we've got one person asking, does the Schwartz formula work for all age groups, neonates up to children?
So yeah, I mean, we use Schwartz in neonates, but it's not really valid until about 18 months. The reason for that is that neonates are born with inherently reduced kidney function. So all neonates have a GFR of about 20 to 30, and that's physiological. That's because there's still ongoing maturation happening in the kidney. So we use it in terms of drug dosing, but there isn't really any valid formula under the age of 18 months. From 18 months to 16 years, we use the Schwartz formula. It's based on height, and there are some pitfalls, as with anything, but it's a pretty good estimate, and you're not going to fall far wrong if you use the Schwartz.
Fantastic. Okay, so let's see if I can get this working. All right, so hopefully you should be able to see my screen. So what we're going to do is, this is obviously going to be interactive because there's not much point just looking at questions and not trying to answer them. So hopefully this is going to work. So if you're on your mobile phones, you can do it on your screens. Go to the website cahoots.it that's up here, and then you just need to enter in this game pin. I'm going to be able to see here how many people are joining, so please do join, otherwise we can't move on and go through the questions. You can choose your own nickname when you log in, so feel free to choose something that's not your actual name if you're a bit shy and you think you're not going to be much good at renal. So yeah, get involved. Okay, we've got our first contender. Excellent. Excellent. And I can see that there are 27 of you in this group chat, so we should hopefully have a good number of people. How the game will work, just while we're waiting for people to get all their nicknames in, is that there will be a question, and then there are going to be 4 options for the answers. You will get points for getting the right answer, but you also get points for how quickly you answer. So this is quite a good platform to be practicing your exam questions, because as you know, in the exam you can be a bit time pressured. So this is good because you get combined points for accuracy and also for managing to answer the question quickly. All right, we've got a few teams coming in. St Heliers versus Brompton. I don't know if that's, I'm assuming that's Brompton in Chelsea. Bit of a cross-London competition. Okay. 15 of you so far. I'll give it another 2 minutes and then we'll get started. Okay, thanks. Andy, a lot of initials going on here. Okay, hello to you too. All right, so I think we will get started. So if you're ready, fingers on the buzzers, and I hope St Heliers and Brompton, you guys have nominated someone to answer these questions for you. So let's get started. Okay, you got to answer before the countdown's up. Okay, gosh, actually quite a large spread of answers there. These are all potentially causes of acute kidney injury. And I will admit that there's going to be a bit of variation depending on where you're going to get your statistics from. However, I've got these statistics directly from past test, which seems to, in my experience, correlate most of what the exam boards think is going on. So autosomal recessive polycystic kidney disease, obviously very rare indeed, and so is cystinuria. So these two are probably your more common things to be thinking about. However, hemolytic uremic syndrome is, according to past tests at least, the most common cause of renal injury. So well done to the three of you who got that right. There's a few of you who I think didn't manage to get an answer in, so please do click something. There's no negative marking, just as there isn't in the exams. All right, so we'll move on to the next question. And MS is at the top there for quick answering. So you're going to get a little case history about Polly. She's 7, she's got bloody diarrhea and an acute kidney injury. She's pale and anemic, and you diagnose her with HUS. So what's going to be the most appropriate first-line management for Polly out of these 4 options? We've only got 4 seconds left. Choose quickly. Excellent. Okay, that's very encouraging indeed. So these are all things that you might think that Polly might need, and depending on how she gets on, she might need these things at different times. Transfusion of packed red cells. Yeah, we did mention that she's anemic, but we didn't talk too much about whether or not she was symptomatic as a result of that. And actually transfusion can put a bit more strain on the kidney in some cases. Hemodialysis, again, that's something that she may need at some stage, but we don't know enough yet to say that she meets any of the indications for dialysis. Antibiotics, of course, can be used to treat infections like E. coli, which can cause HUS, but the benefit of giving antibiotics in these cases is a little bit debatable and a bit more case specific. So the most common treatment that we give children with AKIs, and therefore makes a really good first-line management for Polly, is supportive management only. So as you've heard about from Louise and from Matko today, that might involve fluids, in particular, careful input-output monitoring and things like that. All right, let's see who's got to the top of the leaderboard. Oh, Matko's got in there in 3rd place, but MS still at the top. We've got 3 questions to go, so we'll see who comes out on top. So, same kid, Polly. Which of these would be indications for Polly to start dialysis? And remember, you've got your countdown on the left, so get those answers in. All right, any more for any more? Brilliant. Okay, I think everyone's answered this one, which is a start. Fantastic. Okay, you guys are mostly right. So a metabolic acidosis requiring a bicarbonate correction would be more of an indication for dialysis if the bicarbonate correction wasn't managing to correct that metabolic acidosis. So you may have a situation where you might give a child bicarbonate, but if that sorts out their acidosis, then that doesn't necessarily mean that they would need dialysis. So pulmonary edema not responding to diuretics, or other effects of fluid overload not responding to diuretics could be an indication. That's absolutely correct. So well done, those 11 of you. In terms of your urea, you would want a higher urea than this for that on its own to be an indication for dialysis. And hyponatremia, none of you have put this one. Very well done. Again, as you've heard in a lot of these presentations, it's quite common to have electrolyte disturbances, but you would hope that you might be able to manage those by other methods as opposed to something as aggressive as dialysis. So let's see where we're at. Okay, Em's doing very well indeed. Louise, our wonderful SHO presenter, has crept up to number 2. And well done, Temmie's answered 3 questions right in a row. So 2 more questions to go. Who's going to win? All right, which one of these medications is a recognized cause of acute tubular necrosis in neonates? So we've got some neonatal favorites here: caffeine, Gaviscon, sodium acid phosphate, and gentamicin. Which one of these is going to cause your renal derangement in babies? There's 2 of you. There we go. Amazing. Oh, Absolutely wonderful. So gentamicin is a well-known cause of renal dysfunction, vancomycin as well. You will probably know from your SHO neonatology jobs that it's really commonly used as well, and requires a lot of very careful monitoring of drug levels to make sure that you're not causing your babies any problems. So well done. Because it's such a common drug as well, this is a good one to look out for in your case histories in the exam, because it's such a common first-line antibiotic for neonates. So any problem where there's a neonate with sepsis who then develops kidney problems, that's a good thing to think about in your exam questions. All right. So before the final question, this is where we are. It's very close indeed, within 200 points. Team Brompton have come in there. Then we've got Louise, FN, and Ho Ho Ho. I think must have absolutely smashed that question because they are now on top. So we've got one last question. Ready yourselves. Which of the following combinations of electrolyte disturbance are compatible with the diagnosis of AKI? So which of these might you expect to see in your child who's got AKI? Okay, very good. So in most cases of AKI, and in most cases it you'll see in your exam questions, they actually tend to retain both phosphate and potassium because they're not excreting so much of those electrolytes in their urine. Also be careful of these sorts of questions in your exams because they like to give you combinations of 2 or 3 things, where when you're kind of reading through hundreds and hundreds and hundreds of questions at once, you have to be quite careful that you're selecting the right answer because they all look so similar to your eye. So make sure when you're doing the exam itself, you're reading really carefully what those answers are. You might find it helpful when you've got the physical exam paper, the scrap paper that they give you there, to kind of cross various things out just to make absolutely sure that you're answering how you intended to. So let's see who has won today's renal quiz. Got FN in 3rd place, well done. Matko obviously knows more than I do about renal. And then top is Ho Ho Ho, whoever that is. So very well done. I will now exit this with the fantastic music that accompanies it. So well done, everyone. Hope you enjoyed that. We will do more quizzes with every session of Case Exchange. And we'll try and base them again around exam style questions, trying to work towards the knowledge that the examiners want you to have. And we hope that that helps you to prepare for all of your part 1 and part 2 exams. So if anyone's got any last minute questions for anyone, then do let us know. Again, you can pop them in the chat, or you can also just pop your microphone off mute. I'm going to post that feedback link again in the chat, so please do fill that out so that we can try and make these sessions better for you all. And we will see you all in 2021 with some neonatology.
Please do let us know if you'd like to present a case presentation, and we will see that we can fit you in whichever topic you fall under or want to present in. Thank you.
Thank you, and Sarah, so much for organising that. I actually really enjoyed that last bit. It was really good. Thank you. And thanks everyone for coming.
All right. Happy holidays, everyone. Enjoy the rest of your week.
This conference will now be recorded. This conference will now be recorded.